We have the first paper being presented by Dr. Hari Badari. Yes, what is happening?
Are you waiting for some?
Please start.
No, the
Yes.
screen was waiting for. Respected judges and dear colleagues, a very good afternoon to you all. My name is Dr. Hari Badri Anand, and today I'll be talking on comparing post-operative endophthalmitis rates in operating rooms with or without laminar airflow and high-efficiency particular air filters. Excuse me. Yes.
Please reset the time.
I have no financial interest to disclose. Excuse me, sir. There's a slight
Please
confusion.
restart. Please restart and reset the time.
This is not the presentation that I've uploaded. I think there's been an issue. Could you please check? Sorry about the delay, sir.
This is not the presentation.
That is not the presentation. I've given the new presentation today morning. I've been there only.
Okay.
क्या confusion हो गया?
I don't know why this has happened. I made sure that it was changed also.
This one, right?
Yeah, that is the same thing. See, but it's modified on 27.3. I've given one today morning. I don't know what happened to that. Can you just go back for a session? Go back. Back again. No, back. You don't have anything.
No,
See,
no,
he's
no.
just put it in one master file and he's put it under comprehensive ophthalmology. I think you have to speak with the review room once. This is not my presentation. Can you speak with the review room once? I changed it. I've mentioned it.
I have to check. I don't know the exact executive who have uploaded. There are many executives who are sitting there.
I was sure that it was uploaded. It's not this one.
ये नीचे दिया था अपडेटेड प्रेजेंटेशन, वो इसमें आई नहीं है, वो पुराना वाला है इधर. तो अभी किसने अपडेट किया है, किसने भेजा है यहाँ पे? ये पीसी पे कौन भेजा?
Shall we have the next presentation in the meantime in case there is some glitch in the... What has happened? Is the loading problem? What?
No, sir. This is not my presentation, which is under the name. Like the file name is the same, but the presentation is different, sir. I've checked in the preview room today morning. I
You
think
did not give your.
I have, sir. I have checked and
okay,
I've also checked in the preview
make
room.
it proper.
Yes, sir.
And in the meantime, we have the next presentation. Is the next presentation available with you?
Yeah. प्रणव वैद्य.
With the name of Dr. Swati Shri Naik.
Just a second.
Okay, so Dr. Swati Shri Naik is the presenting author in this next presentation. Her presentation is available?
Yeah.
Okay, please start. And Dr. Hari, in the meantime, just see your presentation and maybe after 2-3 presentation, we'll call you back. Thank you.
Yeah.
A very good afternoon to all of you. I would be presenting on the impact of soft skill training on patient outcomes in ophthalmology residency programs. So soft skills like communication and empathy are crucial for effective patient care, especially in ophthalmology where quality of life is a key concern. These skills enable the doctors to understand the patient's experiences and tailor treatment accordingly. Well, generally it is applicable across all specialties. These are particularly important in ophthalmology due to the diverse treatment modalities and the impact of eye disease on the patient's overall well-being. Despite their importance, formal training in these skills is limited in ophthalmology curricula. So the objective was to evaluate the impact of a structured soft skill training program on patient outcomes in ophthalmology residency program. So it involved 48 postgraduate students and they underwent comprehensive training program that covered communication, teamwork, situational awareness, stress management, professionalism and empathy. There was no comparatory group. The primary outcome was change in patient outcomes, satisfaction scores and physician well-being indicators, and the secondary outcome was qualitative feedback from residents. It was carried over a duration of 1 year. So for communication, the content was effective patient communication that included difficult conversations, explaining the diagnosis and procedures, obtaining informed consent, interprofessional communication, the communication with families and caregivers, and written communication. The methods were various like patient encounters, video analysis, case discussions, and workshops, and for the assessment, peer feedback, faculty evaluation, and OSCEs were carried out. For teamwork, again, it was collaborative practice, conflict resolution, leadership skills, and delegation, understanding the team dynamics, and working effectively. So it was done by team-based projects, simulations, group discussions, and workshops. For situational analysis, recognizing and responding to critical situations, anticipating problems, adapting to changing circumstances, and prioritizing tasks was used, and how they manage time effectively. For stress management, how they developed the coping mechanisms, the time management strategies, and burnout prevention. The methods and assessment were almost the same in all the modules, so that's why I'm not stretching on that. And again, the two other modules taken up was professionalism and empathy. So on the results on chi-square test, to compare the proportion of surgical complications before and after the intervention, there was a 20% reduction in surgical complication and 15% improvement in patient recovery time. The burnout rate among residents decreased by 30% and job satisfaction scores increased by 20%. So traditional clinical outcome measures like visual acuity, they do not always reflect the patient experience. Patient-reported outcome measures capture how the patients experience their vision and its impact on daily life. So these are increasingly being used in research and practice because they provide a more holistic view of the treatment success. So studies shows that even with improved visual acuity, some patients report poor PROMs, often related to difficulties with near vision. Preoperative discussions about existing limitations and expectations are essential. So for example, if glaucoma, they are often present with substantially initially unnoticed patient, and in medication non-adherence is a major challenge. So here the soft skills are essential for creating a non-judgmental space, addressing the patient beliefs and providing personalized education, and to identify and address the psychosocial issues. So finally, to conclude, it demonstrates that soft skill training positively impacts both patient care and physician well-being. Improved communication and teamwork contributed to better surgical outcomes and patient experiences. Enhanced stress management reduced the burnout and increased job satisfaction. And integration of these skills into residency programs has the potential to enhance patient care and physician well-being. So its study provides empirical evidence supporting the inclusion of comprehensive soft skills training in medical education, addressing the critical gap in current ophthalmology curricula. These are my references. Thank you.
Very nice initiative and nice study. Just tell me, who imparted these kind of trainings? Did you take the help of professional peoples in their field?
No, it
For
was
example,
all the
stress management.
Oh, sir, it was the postgraduate teachers only. Like it was the faculties only.
Faculty imparting this particular training.
Yes, sir. Sir, we have not actually included the other departments. Like maybe we can include the psychiatry department as well, but we didn't in this particular study. We have not taken their help.
So how it was done? Did you take some classes on a weekly basis?
Yes, sir.
Daily
Yes, sir.
basis?
Yes, sir. They were given the modules, and they were like by some activities. They were we try to train them like some
It's
a
too complex,
situation.
In so many fields you have assessed. Although it is very good, but
Yes,
seems to
sir.
be a little complex.
Yes, sir.
Even for a resident or for anyone to undergo all these trainings during their training period,
Yeah.
postgraduate training periods.
Yes, sir. So it
First year,
was.
second year, third year.
So it was done over a period of 1 year. So gradually it was introduced. But maybe like sir, better like in the further years, we were just trying to see like whether it is working out or not, because we didn't find out so many studies related
All
to
your
that.
residents participated in the study?
Yes, sir.
Incidentally, I was the chairman of Medical Education Technology Department at my college, Atal Bihari Vajpayee Institute and RML Hospital. And I have an experience of calling and inviting psychologists for imparting soft training to residents, and they were a great help. Apart from research methodology, it's a very good initiative.
Yes, sir. Yes, sir.
Thank you very much.
Thank you, sir.
Thank you. Now, next, Dr. Desai. As Dr. Desai is here, Dr. Forum Jitendra Desai. Dr. Desai present? Okay. So we are marking Dr. Desai as absent. We have no information. Okay, we'll wait for some time.
What we will do, we will not mark her absent at the moment.
At the moment, we are keeping her in absence. Okay, Dr. Daulat Thakur, please.
Can you help me? Excuse me?
Duplication of the original language.
Good afternoon, everyone. My topic is Igniting Research Aptitude in Budding Ophthalmologists. Neil Armstrong said, research is creating new knowledge. Without research, the conference halls would be empty and journals would have nothing to publish. Thesis is an integral part of MS syllabus, but there are hurdles, very high workload in OPD and very hectic schedule of postgraduate trainees, which include seminars, journal clubs, emergency duties. More importantly, students are less interested in research and more interested in surgeries, which gives them the bragging rights. On top of this, National Medical Commission has introduced new guidelines which say that every PGT must present in a state or a national conference and if possible publish. So difficulty is double. We have a thesis which we can't present or publish before the exam, and we have to do new research which has to be presented in a state or a national conference. My challenge was to develop a research project which would be accepted at least at a national conference in a peripheral medical college which is about 130 kilometers from Calcutta, keeping in mind the limited infrastructure. So we have 2 PGTs per year, and we literally started from scratch because there were no presentations before this, and the standard protocol included planning a research topic, getting clearance from the ethics committee, analyzing data and sending the abstracts to various conferences. We had 53 presentations in state conferences of West Bengal and DOS. The difficult part was getting accepted in a national conference because the acceptance rate is very low. And I am glad to say that there were 40 presentations during the 5 years by my PGTs. And this was beyond my dream, beyond my imagination. International presentations by PGTs, and we had 17 of them, including APAO, SAOCON, and World Ophthalmology Congress. And this was possible because of COVID. Every cloud has a silver lining, and because of virtual platforms, all the residents could simultaneously attend the conference at a nominal cost without bearing the travel and hotel costs. So total of 110 presentations, and some of them are over here, which are included from the national and the international presentations. Awards are a huge motivating factor, and I'm proud to say that my team members have won quite a few awards, including first prize in DOS 2020 and third prize in DOS 2021, and Dr. K.P. Roy Memorial Award from the West Bengal State Conference, which was open to all young ophthalmologists below 40 years, and it was not reserved for PGTs. Some of the publications are highlighted over here, and some are still in the pipeline. So I would like to conclude that it takes a lot of time from planting a seed to grow to a tree which gives fruits, but we should continue to motivate students to do research so that science moves forward. Basically, it's a teamwork, and I would like to thank all my seniors, colleagues, and juniors for their cooperation and collaboration. And this is the best gift I have received in my life from my PGTs. I'm proud to say that all my PGTs have presented at least one paper in a national conference, and I think that is an achievement. And all the teachers in the hall would appreciate the effort behind this. Thank you.
Wonderful. Obviously, research is so important. USA is USA, Europe is Europe because of the research activities there. And now we are also catching up, and
Yes.
research methodology has become now I think mandatory for postgraduate students
Yes,
also,
sir.
I think.
Yes, sir.
So,
They have to do statistics course also before they.
biostatistics also.
Biostatistics.
Yes, yes. So any comments?
This is very good thing. Just tell me, these papers, they were their primary work or the collective work of your OPD or your hospital which they presented as a presenting?
No, no, this is their primary work. The patients were from the OPD, obviously, but they have.
So beside the thesis work, they have
Besides the
paper
thesis
work.
work, they have done this something extra.
That is
bec-
good thing. That is good. Because normally what we see, we just see a presentation from the collective work.
No, sir. This is their primary work, and I am glad to say that these awards helped me a lot. Once
That is fantastic.
somebody got an award, then others were there was a seismic boost, and others were trying to do 2 or 3 projects so that their chances of getting an award increase.
Thank you very much. Thank you.
Thank you.
Very good.
So ignition is more important than the awards, basically.
Yeah, but awards give a boost
Boost to them. Of course, yes.
Dr. Vidya Verma, please. Okay. Dr. Hari's, your presentation is ready. Please come. Dr. Vidya Verma is here. Sorry.
FP366.
Okay, Dr. Desai. Okay, fine. You did not inform us. In fact, anyhow, no problem. We got in.
That's the updated
Thank
one,
you.
right? This is the updated one, yes. Thank you. Sorry about all the confusion. I didn't know what we do. It happens, sir.
Respected judges and dear colleagues, a very good afternoon to you all. My name is Dr. Hari Badri Anand, and today I'm here to speak to you about comparing postoperative endophthalmitis in operating rooms with or without laminar airflow and high efficiency particulate air filters. I have no financial interest to disclose. Now, looking at cataract surgeries, are the most commonly performed surgeries worldwide, with 20 million surgeries performed per year. And postoperative endophthalmitis is a very rare complication with incidence rates ranging from 0.03 to 0.21%. In 1927, Dr. Lidwell et al. Came out with a paper which talked about surgical site infections in post-arthroscopy and post-hip replacement patients, which were attributed to airborne bacteria, after which operating rooms with laminar airflow and HEPA filters have been the standard worldwide. But the question comes to whether the cost-benefit analysis is actually there because of the increased demands of energy, the increased cost of construction, and also increased pollution, which occurs as a result of all the expensive systems that we are using for air handling in operating theaters. Now, in 2020 and afterwards, an interesting series of papers came out on whether phacoemulsification, which is the most commonly performed procedure, generates aerosols or not. And we have conclusive evidence which says that it is not a high aerosol generating procedure, unlike the orthopedic surgeries on which the need for HEPA has been established as of today. So we had a confusion as to whether we needed these high-end systems in ophthalmic ORs, and we turned to our hospital system, which has a total of 17 surgical units with a variety of air handling units, namely Group 1, which is laminar airflow with HEPA filters, Group 2, central air conditioning with HEPA filters, Group 3, central air conditioning without HEPA filters, and Group 4, split air conditioning. So we did a retrospective consecutive case series analysis on these. Looking at the already established literature from our institute on how we could use flash sterilization to drop endophthalmitis rates, and also how we could use intracameral moxifloxacin to significantly reduce postoperative endophthalmitis, we also decided to seek out whether we would need high-end filtration systems in our operating rooms. So as mentioned earlier, we analyzed all the cataract surgeries performed across all our institutes in 2023, which numbered to 450,000 plus. Looking at the split of cases, it was across, it was around 280,000 and more surgeries as MIS-SES, and over 170,000 surgeries as PHACOs. Now, looking at the post-op endophthalmitis rates from the same and the number of surgeries across all groups were almost similar, ranging from 93,000 in Group 3, which is AC without HEPA, to 128,000 in Group 2, which is AC with HEPA. Now, looking at the endophthalmitis rates, we had a total of 74 patients and 14 who turned culture positive. And the rates in group 1 through 4 were 0.013, 0.016, 0.017, and 0.019% respectively, with a p-value greater than 0.05, which negated any statistically significant difference between the 4 groups. Also looking at whether there were any differences between phacoemulsification or SICS as a procedure for the same, we noticed that the numbers are as follows, and the p-values are all above 0.05, which means that there is no statistically significant difference. Also looking at whether the paying side of the hospital and the charitable side of the hospital would have had different practices or difference in endophthalmitis rates across the operating rooms. Again, the numbers showed us that the p-values all numbered more than 0.05, which clearly shows us that we do not need laminar airflow or high efficiency particulate air filters to work towards safe cataract surgeries and lesser rates of postoperative endophthalmitis in ophthalmic operating rooms. Thank you.
So what is your conclusion for ophthalmic surgery? Is LAF plus HEPA is required or not?
No, sir, it is not required because
required.
the postoperative endophthalmitis.
NABH accreditation?
Yes, sir.
They
With
don't
respect to the recent NABH accreditations, ophthalmic operative rooms have been brought under Type 2. So they've been erstwhile mentioned as general OTs, but now they've been put under a special classification, wherein they do not mandate laminar airflow, but they would suggest that all hospitals have laminar airflow and HEPA filters with positive pressure on throughout the day, 24/7, even when working and not working in all the operating
Till
rooms.
very recently, they were not giving accreditation without
No,
HEPA.
sir, they weren't. I just had a look at the guidelines today morning as well, sir, which is the one that I'm referring to, wherein Type A and Type B are there. Type A is for super specialty surgeries, especially aerosol generating procedures such as hip replacement such from orthopedics. Type B is where our OT falls in right now, which is ophthalmic surgeries, erstwhile called as general OTs, but now a special category. Still, the guidelines are a bit vague on whether we have to use them or not, and this, whatever data we have concluded from our study would go a long way in helping them make a decision, an informed decision for the
Yes,
same.
you're right. This data is going to help us.
Yes, sir.
Fine. Similarly, more data from different centers need to come.
Definitely, sir, yes.
Fine, so that there can be a collective data
Yes, sir.
which shows that yes, this and without filtration, it is same thing.
Yes, sir.
Did you encounter any cluster endophthalmitis also?
No, sir. So routinely in our system, we have a concept of infection control meetings which happen at the end of every financial year. So it'll be in the late week of March, wherein we analyze the entire year. So speaking for 2023 and 2024, we didn't have clusters per se, but we've noticed that always the endophthalmitis rates are a bit higher among the summer months, so March, April, and May. We have not noticed any clusters in 2023 in our centers.
This data is from one center.
No, sir. It's from the entire system. So it's a total of 14 centers
14
and 17 surgical units, sir. So surgical units
It's
might
all
be different
collective
between
data.
centers. Everything put together, yes, sir.
Good. No, we need to have more data from more centers, fine, from all over the country, so that these recommendations can be shared with NABH authorities. Fine. Thank you very much. Nice,
Thank you, sir.
nice work.
Thank you.
Nice work. Thank you. Now, Dr. Desai, I call you. Please come.
It's not mine. Can you please put my presentation? FP 726. Good afternoon, everyone. I would like to discuss ocular manifestations of systemically administered sulfonamides and their treatment. Yes, this is mine.
I think, sir, speakers here.
So I did this study with the, as we all know, with the AIM. Sulfonamide group of drugs are routinely prescribed for various systemic conditions as well as after or before ophthalmic surgeries and for glaucoma. Their ocular side effects can mimic other common eye disorders. So precise knowledge of these manifestations can aid in reaching a correct diagnosis. As we all know that our eyes see what our mind knows. Many of the times our mind knows, but then the manifestations can present in different, with different signs and symptoms, often leading to confusion as to what the diagnosis is. So this study was done to study different presentations. We assessed patients presenting to our OPD who were on sulfonamides for varying duration and indications. So case 1, a 22-year-old female presented to us with sudden painless dimness of vision for 1 day. There was no history of using glasses and she was on tablet Topaz 25, that is topiramate, for 2 weeks. Her uncorrected visual acuity was 3/60, which improved to 6/6 with -5 diopter spherical correction. Her IOP was normal. There was 360-degree appositional angle closure and the fundus was normal. Had we not known the history and about the disease entity, it could have been easily passed on as a primary angle closure suspect or a normal refractive error. But the diagnosis was clinched because there was acute presentation, induced myopia, bilaterally shallow AC, and 360-degree angle closure, appositional angle closure, and ciliary effusion. Patient was asked to stop the tablet, put on atropine drops, and by 5th day, her angles were open and the vision was 6/6. This is another case. A 40-year-old male patient presented with sudden blurring of vision in left eye, which was associated with severe pain and redness. His right eye had become phthysical following a trauma in the childhood. He had history of chronic headache. His uncorrected visual acuity that day was 3/60. He was using glasses, and with those glasses, his visual acuity was 6/36, and his visual acuity improved to 6/9 with correction of -6.75. So this was his clinical picture. There was mild congestion, little chemosis, corneal edema, shallowing of AC, pupillary reaction was sluggish, IOP was 52 millimeters of mercury, gonioscopy showed appositional angle closure, AIOS2025 showed narrowing of angle, ciliary effusion was seen on UBM, the disc was healthy but there were few ILMs trial. So topiramate-induced angle closure was considered to be the diagnosis. What is important to know here is if the patient was considered to be having acute angle closure, then the treatment would have been pilocarpine and a PI would have been done. But actually the patient needed atropine eye drops which were given to him. He was weaned off topiramate and by 5th day he got better. This is another 21-year-old female presented to us with blurring of vision since 2 days and was referred for PI. Her IOP was high and had myopic shift. Again, topiramate was discontinued, and after that, her vision was good. This is interesting case of 32-year-old male. He was army man. He was emetrope as per the history and records of army hospital. He had complained of sudden painless DOV that morning. He had taken a single Dimox tablet the previous night as a systemic prophylaxis for Ladakh posting. On stopping Dimox, his AC eventually deepened, and as you can see, the UBM also showed ciliary effusion. So sulfonamides can cause idiosyncratic reaction which leads to anterior rotation of ciliary body, seriochoroidal effusion, and thereby induce myopia. The presentation is almost always bilateral. Withdrawal of sulfa drug is the key. There is no role of laser iridotomy or pilocarpine. Atropine helps in deepening of anterior chamber. IOP can be normal in such patients in spite of the appositional closure, and anti-glaucoma medications should be added if required. One must always remember that the best clinical tool in such cases is a good history taking. And just as we need to know about systemic complications of whatever drugs we are prescribing, it is very important that we spread a word to our physician friends regarding the ophthalmic manifestation of sulfa drugs. You must have seen that Dimox, in spite of knowing many of us loosely use Dimox, even after cataract surgery, such cases of acute angle closure are seen. So a good knowledge and putting this into application can help many patients. Thank you.
Thank you very much. You are right, high degree of suspicion and good history taking is paramount. Yes, thank you. Dr. Vidya Verma, please. Sorry, please come. What you're saying? Oh, you are a co-author, not a presenting author. Okay, fine. That is allowed. That is allowed, but as the rule says, the presenting author only will be eligible for the awards. So we will definitely give you the marks, but this will not be included for awards. Okay? Please come.
Good morning, I am Dr. Nikita Ahuja, and I would be presenting the role of MRI in assessing non-traumatic orbital lesions in observational study in central India. MRI, that is magnetic resonance imaging, plays a crucial role in assessing orbital and neuro-ophthalmic disorders, offering superior soft tissue contrast compared to CT. Diagnostic accuracy of MRI and orbital lesions depend on various factors including lesion type, location, and imaging protocol. The aims and objectives would be to evaluate the role of MRI in assessing non-traumatic orbital lesions, focusing on location and type, to correlate MRI findings with clinical and histopathological data, and to assess MRI's diagnostic accuracy and enroll treatment planning. This was a hospital-based observational study done in a tertiary care center with sample size of 60 patients with non-traumatic orbital lesions presenting with proptosis, diminution of vision and diplopia, with or without suspected metastasis to the orbit or invasion from intra or extracorneal lesions. The ethical clearance was taken, the demographic data was written, and patients underwent MRI with T1 and T2 weighted images, fat suppressed sequences, contrast enhanced imaging, and diffuse weighted imaging. In different planes taken, data were analyzed descriptively and statistically. Patients with suspected metallic foreign body with ferromagnetic implants, contraindication to contrast agents, and claustrophobia, and those who did not give consent were excluded. Final confirmation of the diagnosis was done by histopathological examination. Histopathology and CT correlations were performed if required. Collected data were recorded on MS Excel sheet, percentage mean and standard deviation, relative ratio, and p-values were calculated. So let us see some cases like retinoblastoma, in which the axial T1 weighted image shows heterogeneous hypointense mass in the chorioretinal layer with extraocular extension. On contrast, shows intense enhancement, and correlative CT shows a heterogeneous mass with calcification. Coming to orbital lymphoma, where coronal T2 fat suppressed T1 axial images show mild low intensity lesion involving supralateral aspect in the extracorneal lesion. Mild thickening and enhancement of edges in conjunctiva can also be seen in T1 post-contrast imaging. Optic nerve meningioma, where axial flare T2 suppressed, T2 fat suppressed in T1 post-contrast sequence showing heterogeneous hypo-intense lesion in intracorneal space along the optic nerve. Then lymphovenous malformation and cavernous hemangioma. In this, we can see the sagittal T1 image shows heterogeneous lesion in extracorneal space with few T1 hyperintensities, where T2 axial and coronal image shows fluid level. Gadolinium enhanced MRI shows helps in evaluating vascularity, blood-brain barrier disruption, and inflammatory changes. And in cavernous hemangioma, the T1 weighted axial image shows heterogeneous lesion in extracorneal compartment. The results was the diagnostic accuracy in specific lesions was orbital tumor sensitivity came out to be 90% and specificity 85%, with MRI effectively differentiates benign from malignant tumors. Optic nerve pathologies, MRI is superior to CT for optic nerve gliomas and meningiomas. Inflammatory, which is the most common etiology, in which the most common was preseptal cellulitis, and neoplastic lesions, in which the most common was lymphoma. MRI has high accuracy. In distinguishing these conditions, difficulty in detecting subtle bone erosions, where CT was found to be superior. So, in some studies, it was stated that MRI effectively differentiates intraocular tumors. MRI provides exceptional detail of intracranial anatomy, and in Deepwater et al. Study, it is useful for detecting small intraocular tumors and assessing neoplasms. The strengths and limitations of the study were the study covers a wide range of orbital pathologies, providing a holistic view of orbital imaging. The study links imaging findings with clinical presentation, aiding in differential diagnosis and providing Patients' management strategies. The study does not discuss the financial and logistical constraints of the MRI over CT in routine clinical practice. Further, some vascular lesions and neoplasms have overlapping images characteristics, making differentiation challenging despite modality enhancement. So to conclude, this study highlights area for future research to improve the understanding and assessment of non-traumatic orbital lesions. MRI is essential for diagnosing non-traumatic orbital lesions, provide detailed anatomical insights, and enhances diagnostic accuracy and patient management. Crucial for evaluating orbital neoplasms, assessing ocular structures, perineural spread, and intracranial extension. Thank you.
Very nice presentation. Sorry. So MRI is well known for such kind of lesions, orbital lesions for responsible for proptosis, orbital epic syndrome, superior orbital fissure syndrome, cavernous sinus thrombosis, intracranial secondaries or primaries. It's very well known. I mean, what extra have you given to?
Sir, in certain conditions like I listed in my PPT, like
Is MRI versus CT scan or just an MRI for any orbital lesion? Naturally, any orbital lesion, any suspected orbital lesion, you subject to imaging, fine. And definitely MRI has a upper hand than CT scan.
yes, sir.
So what is the new in this study? Did you compare with the CT scan or in those cases where the CT scan has upper hand, where there you could have shown that yes, MRI also can give, I give you an example, or I ask you, in thyroid eye disease, what will you do, MRI or CT scan?
Sir, MRI. So we'll go for MRI to see if CT would, we do CT and MRI both, but MRI would be of greater importance in looking for soft tissues like muscle involvements and
That is visible on CT
CT
scan
also.
also. You want to see the fat enhancement, hypertrophy, you want to see the muscle. So that is visible primarily on CT scan also. If you want to have, if you have to do orbital decompression, then definitely you have to do CT scan because there you need to study the bone in this. So not in all cases you do just go do MRI. MRI or any imaging is the thing for any orbital lesion. Nothing new in this study. That is what I feel. Thank you very much for still presenting it.
Thank you, sir.
Dr. Vaishal. Dr. Vaishal Kenya, please. Dr. Vaishal Kenya is there for IUL Master versus Interior. Okay. Dr. Barua. Dr. Parishmita Barua. Dr. Sandhya. Dr. Sandhya. Dr. Arpita Singh. Dr. Nikita Dash.
Very good afternoon, everyone. Today I'll be presenting on clinical and treatment profile of adult uveitis at a tertiary care center in urban North India. And I have no financial interest. So we know that uveitis is an inflammation of uveal tract and can be accompanied with inflammation of adjacent ocular structure. And there have been many studies regarding the incidence of uveitis. However, very few studies have commented on the treatment profile of adult uveitis in India. So our purpose is to study the clinical profile of adult uveitis at tertiary care center in urban North India. It's a single center cross-sectional study from April 2023 to June 2024. We have taken into consideration uveitic patients of age more than 15 years, age, sex, laterality, site of involvement, complications, best corrected visual acuity, etiology, and treatment profile were noted. A total of 78 patients were included. So my demographics included 54% of males, 46% females, and the majority of the age distribution, it belonged to 26 to 50 age group category with an average age of 34.56 years. And in our study, we saw that about 68% of cases were bilateral. And now coming to the distribution of uveitis, in our study we found that there were about close to 49% of patients they had posterior involvement, followed by a good anterior involvement by about 35% of cases. And as you can see that the entity of posterior uveitis, there were a lot of like vasculitis and vitritis that took up majority of the portion, followed by choroiditis and tuberculoma. And infectious cases were noticed in about 35% cases, with predominant being TB, and non-infectious about 65%, with most predominant being idiopathic. And then we'll come to the treatment profile. Now these are the abbreviations that I've used. So, SI stands for systemic immunosuppression, which including steroids as well as other non-steroidal immunosuppression, and ATT, anti-tubercular therapy. As you can see, in vision less than 6/60, the predominant pathology was TB retinitis, and we had to give certain systemic drugs, ATT or systemic immunosuppression. And majority of the patients with vision, poor vision, they had about 6/9 to 6/60, and in these we had to give systemic immunosuppression in most of these cases. And coming to the complications, it was seen in about 46.2%, and the most common complication was complicated cataract due to systemic corticosteroid, and second most common being cystoid macular edema. Now we compared it to the recent studies, and when we compared our uveitis profile and complication profile, the most significant thing that we noticed was the laterality. Our had a more bilateral cases. Rest idiopathic and posterior involvement was similar with the other studies. And our study had used the most immunosuppression. About 42.3% of patients had to be started on immunosuppression to suppress the uveitis. And some studies had not studied immunosuppression, and this study they only had 18% of cases on immunosuppression. So I would like to conclude saying that steroid-sparing immunosuppression in adult uveitis should be considered in long-standing diseases, and rheumatologist referral, it would be very helpful for comprehensive ophthalmologists when dealing with adult uveitis. And more importantly, a good fundus examination before starting any corticosteroid therapy or systemic immunosuppression is essential. So thank you.
I have a question.
Yes, sir.
For tuberculosis and other infective etiologies, how you proved it? By PCR, by vitreous culture?
No, sir. We have to do a MANTU, then chest X-ray, not chest, but we do a CT thorax. Any CT.
Systemic tuberculosis.
Yes, systemic tuberculosis.
Involving the ocular tissue.
Ocular TB, sir,
Did you
that
do
is.
something from the ocular tissues?
No, we did not do any. Ocular tissue involvement, sir, that's a clinical finding. Clinical finding. That is clinical. So we get to know tuberculoma, that is, or any choroiditis in a systemic TB patient, that is enough to give us a suggestion that most likely that is due to the
biopsies or vitreous culture?
no, sir, no invasive, nothing to do, no invasive.
Clinical.
Yes, so because clinical is more important.
Nothing from the aqueous is also.
No, nothing from the aqueous. If it is systemically already present and there is also a clinical presentation. So HIV, that is also mostly clinical. HIV
You did not do any
retinitis.
aqueous tap or vitreous tap or any serological tests or MONTU or X-ray tests like that? You just went by clinical picture?
So mostly.
In one of your pictures, just show me you have tabulated your treatment according to the visual acuity. If the vision is this much, then the treatment is
No,
like
sir.
this.
We are just saying that with the patients in the age group of this vision, with the range of that vision, these all treatment have been given. The treatment profile was this. Obviously, it's a tailored treatment profile. We cannot give everything to everyone. Ultimately, uveitis is a very tailored treatment profile. We'll have to judge. Like supposing if there is a retinitis and you're thinking that is also going into an NV, you first have to wait for the retinitis to subside,
or for the vasculitis to subside, and then you can go ahead with the sectoral laser. There is not a like one shoe fits all in uveitis. At the end of the day, it's a very, very tailored treatment. We just give a like basic treatment profile that these are all that treatment that can be given. Thank you, sir.
Dr. Priyadarshini Mishra. Dr. Priyadarshini Mishra. Sorry. Dr. Virajita. Oh, thank you. How her name cropped up here?
JN is Gya actually. It's Big Gya.
Okay.
Here or there? So good afternoon everyone. I am Dr. Bigya Panda from AIOS Bhubaneswar, and I will be presenting my survey on practice patterns about the management of oculoplastic conditions in the preoperative period among Indian ophthalmologists. So according to the literature, the prevalence of oculoplastic conditions varies from 1.4% to 7.4% of new eye patients, all presenting to a eye clinic. And the presence of these oculoplastic conditions along with a patient with glaucoma or cataract or any vitreoretinal condition that affects the surgical planning and the outcomes. And these post-operative outcomes have an impact on the patient satisfaction as well as the ophthalmic surgeon reputation. So as the preoperative management practices varies among the ophthalmologists, that is a diverse practice pattern, we need to understand how the concomitant oculoplastic conditions are managed by the general ophthalmologist and the subspecialty surgeons. So our goal was to identify the common practices and the potential gaps if present, and the potential for any standardized care could be performed. So this was a cross-sectional questionnaire-based study between April and June 2023, and it included around 180 ophthalmic surgeons all over India. Ethical approval is obtained, and the data was analyzed using excellence data. So this was the proforma we gave by Google Sheets to all the ophthalmologists. So these proforma included questions related to the demography and about the oculoplastic conditions they see in the OPD, and how they manage these oculoplastic conditions before sending their patients for any subspecialty surgery. So the participant demographics included 52.2% of female ophthalmologists, majority in the range of 30 to 40 years, and within 5 to 20 years of practice, mostly belong to the urban areas. The ophthalmologists were mostly comprehensive, and they were also fellowship trained subspecialists. So regarding the oculoplastic practice patterns, like how many oculoplastic conditions they see in the OPD and whether they manage on their own or they refer to any specialist. So, according to the results, what we found was that around 43.8% they referred the oculoplastic disorders to a specialist, and only 16.3% they practiced exclusively their subspecialty, and they referred all patients to the specialist. So regarding the concomitant lacrimal conditions like chronic dacryocystitis or NLD obstruction, 49.7% preferred Roplas testing as the sole screening procedure, and 63% favored dacryocysto-rhinostomy before they sending the patient for cataract surgery. And 13% around they chose punctal cautery or they proceed with ocular surgery in asymptomatic cases. So in partial NLDO, around 50% they proceeded with ocular surgery in asymptomatic cases. Most of the ophthalmologists, they favored a gap of at least 4 weeks before any subspecialty procedures. Regarding the eyelid malposition management like entropion, ectropion or ptosis, 43% favored surgical treatment prior to the subspecialty surgery. If the thyroid eye disease was present, around 47% they treated the patients in selective cases only, and rest proceeded for the ocular surgery. The anesthesia they preferred before doing any specialty surgery was the topical anesthesia. So most of the ophthalmologists, they treated, around 97% treated all cases of periocular infections like lesion, stye or canaliculitis before doing the surgery. So the limitations of our study was that it included only the Indian ophthalmologist and the global perspectives were not considered. There was a small sample size and there were some questionnaire gaps too. So to conclude, there is a variability in the practice patterns which reflects the diverse training backgrounds of the ophthalmologist. There is a need to integrate comprehensive oculoplastic training in all residency programs, and there is a call for standardized guidelines and collaborative efforts among subspecialties. Thank you.
This term, common practice patterns, you know, it has a very significant value in medical legal cases. In your questionnaire, what it was related to? Only dacryology,
All the
thyroid disease,
oculoplastic
whole of
conditions,
the
right?
oculoplasty. Because just 180 consultants, we are almost 12,000 attending here,
Right.
to 18,000 All India Ophthalmology Society members. More than this are which are not even society members. So almost we can say 30,000 ophthalmologists working in India.
Right.
We oculoplastics, I am an oculoplastic surgeon. So our oculoplastic society as such has 1,400 members.
Right. So I'm also an oculoplastic
Yes.
surgeon.
So-
So I
that is
wanted
what-
to
that-
take
that
it
is
into
what-
the
that is
oculoplastic
why,
group
because
also.
if you are an oculoplastic surgeon, your role was supposed to be little more concise. Maybe just on one point, okay, yes, if there is a epiphora, what a general practitioner do, what a
Yeah.
ophthalmologist do, and as
Yeah.
such, or when they have to decide for a surgery.
Hmm.
Like in your case, you said, okay, 50%, even if the infection is present, NLDO partial or complete, they proceed with the cataract surgery.
Surgery, yeah.
If there is endophthalmitis there, it is indefensible.
Hmm.
That is what I said, this common practice patterns is a very critical term when medical legal cases are there.
Okay.
Fine.
So
if
that
we-
is why I'm telling there is a need for creating these guidelines which should be followed by
So
all
best
ophthalmologists.
best will
Still
be
now
to
it
have
has not
one
been there.
condition in case this kind of a practice patterns you want to actually study, because difficult to study the entropion, ectropion.
I was
Right.
going
etc.
to ask
in
you.
one case,
I was
in
going
one
to
case
ask you
study.
the same question. In
Ah.
other words, that what was the purpose of the study?
Purpose of the study.
No,
yes.
like chronic dacryocystitis have been majorly studied in all,
That
like
is what
whatever
we are-
literature
that
is
what we are
there.
emphasizing.
That is what he's saying. If you take
That
one condition one by one,
only,
we can
one condition
conclude.
because it has
Yeah.
a value.
We can conclude
Like
something.
The
in her
eyelid
presentation,
malpositions like
like in her
ectropion or
presentation,
entropion.
She concluded that yes, steroid sparing immunosuppression and referral to rheumatologist is very essential, isn't it? That is what her study definitely concluded. But in your initiative, you have taken some initiative, yes, it should be pinpointed initiative so that if suppose these guidelines or these things comes to a resident, at least they get something out of it. Because at the moment it is not able for me, I'm not able to digest that partial LLDO 50% will operate.
Yeah, if
Fine.
symptomatic,
That is what I'm saying.
then we
Again,
operate.
partial NLDO, fine, whether symptomatic, asymptomatic, unless and until you have taken a consent from the patient, okay, yes, there is a high risk
Yeah.
of developing an endophthalmitis because no one will operate.
But I think
Sir.
it gave her a lot of information as an oculoplastic surgeon that what general ophthalmologists are doing about different conditions.
So I wanted
That
to
would be of, I think,
find
interest
out
to you.
that only.
So
So how they are treating, whether they are treating the ectropion or entropion or not, because that has also a very important role.
So that is what I'm saying. Okay, with this is each topic-wise questionnaire, so that we get some answer out of it. It
So
is not
the
that we
questionnaire
include-
was included because of lack of time. I
Anyway,
could not show
as
the
of this
questionnaire.
presentation, I'm talking of this presentation, including so many things in one questionnaire and then asking the practice patterns is, I don't know, has served a purpose.
Because she is an oculoplastic surgeon and she was interested in what general practitioners are doing about all the conditions. How
Yeah,
many
for
they are
the
referring.
oculoplastic conditions,
Anyhow,
how
good
they
initiative,
treat.
that is
That's
what
all
I
right,
say.
good.
Good
Yeah.
initiative. Thank you. I call the names back again. Is Dr. Vishal Kenya has come. Okay, so we are marking it as absent. Fine.
Last.
Dr. Barua's paper, I think, has been withdrawn. And then we have Dr. Sandhya. Has Dr. Sandhya come for her paper on corneal changes in type 2 diabetes? Okay, we are marking it as absent. Then Dr. Arpita Singh for her paper on PCOS, insulin resistance and tear functions. So we are marking absent. So the last is Dr. Lakshay Sharma, please.
Good morning, everyone. I'm going to present my findings on a paper that we are about to publish, the effects of pterygium excision on IOL power calculation and its correlation with pterygium size.
Sorry to withhold, sir. You are not a ratified member.
Sir?
You are not a ratified member.
Sir, I'm a member. I'm a presenting author. The chief author is Dr. Abha ma'am.
Whosoever is the presenting author, as per the rules, they have to be ratified members. So we will be marking your paper, but this will not go for the awards.
Sir,
Okay, that is what rule says.
Okay, sir.
If the presenting author is not a ratified member of AIOS,
Sir, I'm a member of the...
no, but you are Dr. Lakshay.
Yes, sir, I'm registered.
No, not registered.
Okay, ratified.
The ratified life member of All India Ophthalmology
Yes, sir,
Society.
I'm a life-
Your membership number is
Anybody whose name has been
29647.
approved by general body meeting also.
Okay.
Okay, I'll clarify. Your membership number is 29647.
Yes, sir.
As of now, only up to 28,934 number is ratified.
Okay, sir.
Beyond that has not been ratified. Maybe they will be ratified in this particular coming general body.
Okay, sir.
So as of now, you are not a ratified member. We are marking your paper, but it will not go for awards. That is what is the information you must have.
Okay, sir.
Okay, sir. Thank you.
So prolonged exposure to UV radiation contributes to simultaneous occurrence of pterygium and cataract. It's a prevalent condition among elderly. A large pterygium can induce significant corneal astigmatism and consequently affect the accuracy of intraocular lens power calculation. The prevailing treatment for pterygium is surgical excision, which notably increases the spherical power of the cornea, while a significant reduction in the astigmatism has been observed. Calculation of an accurate IOL power is essential for enhancing visual and refractive outcomes in these cases. And till date, systematic studies are lacking on the predictability of IOL power in combined or sequential cataract and pterygium surgeries. Therefore, the study was aimed to assess the refractive accuracy of the calculated IOL power in these patients. Our prime objective was to compare the changes in IOL power before and 1 month after the pterygium excision surgery. And the secondary objective was the correlation between IOL power and keratometry with the size of primary pterygium. Our study period was 12 months, and it was a comparative interventional analytical study in the Department of Ophthalmology, SMSR, and our study population was 45 patients. Keratometry and biometry of all the patients was done prior to the surgery and 1 month after the surgery. All the patients underwent pterygium excision with conjunctival limbal autograft by a single experienced surgeon. The preoperative assessment included best corrected visual acuity, a standard slit lamp examination, dilated evaluation to rule out any fundus pathologies or any macular edema or any lens displacements. And keratometry was done, biometry was done using an A scan, using immersion technique, and using a SRKT formula. The IOL power was calculated with the standard A constant of 118.2. Horizontal pterygium length and vertical width was measured using a Castro-Weher calipers preoperatively. Our inclusion criteria included patients from 40 to 80 years with primary nasal pterygium sizing from 2 to 4 mm, consenting for pterygium surgery, and exclusion criteria was previous ocular trauma or surgeries, and subjects with corneal ectasia such as keratoconus, dislocated or subluxated lenses, posterior staphyloma, pathological myopia, macular edema due to any retinal pathology. In the results, the mean age was 53 plus minus 16.2 years. Mean horizontal pterygium length was 2.3 to 0.9 plus minus 0.9 millimeters. The mean pterygium vertical width was 4.6 plus minus 1.1 millimeters. the mean keratometry readings before and after the sterism surgery was evaluated, and it showed that the keratometry post-operatively increased to 45.35 plus minus 1.32, which came out to be significant. The axial length post-operatively increased up to 22.72 plus minus 0.68, and it came out to be insignificant. The reason for insignificance came out to be the biometry technique we were using. If we would have been using a optical biometer, it might have come significant. The IOL power significantly decreased, and the corneal astigmatism also decreased. Post-excision stability of the cornea was that the astigmatism was reduced. IOL power shifted towards, there was a clear myopic shift of almost 0.3 to 0.5 diopters with due to corneal steepening. The size dependent changes was that the pterygium, more than 45% of the corneal radius or near the visual axis induced significant refractive alterations. Preoperative considerations were surgical planning. Surgeons was accounting for postoperative corneal remodeling when selecting the IOL power. So to finally conclude, due to irregular astigmatism and keratometric inaccuracy, there is a myopic shift after the pterygium excision. In the study, findings was that the IOL power was significantly less after the pterygium excision. The changes primarily result from the biochemical influence of the pterygium on the cornea, and its removal induced corneal remodeling. It was noted that the sequential pterygium excision and phacoemulsification surgery with implantation of monofocal IOL in an effective method, then the combined technique, if the size of the pterygium was more than 2 mm, the key observation that the length of the pterygium contributed to considerable variability in IOL power, noticeable myopic shift, and the pterygium excision before cataract surgery optimizes our IOL power accuracy. And to conclude, in this modern world, when the patients are paying our high prices for premium lenses, an accurate IOL power calculation is very mandatory to for patient satisfaction as well as a medical legal purpose. Thank you.
So your recommendation is, if there is a pterygium of more than 2 millimeter, you do the pterygium surgery first and wait and then do the IOL surgery.
Sir, there have been
yes.
So there have been multiple studies which combine sequential as well as combined. Sir, we propose that we should wait for at least a month for the corneal remodeling to happen.
That's what I'm asking.
Yes, sir, yes.
If it is more than 2 millimeter,
Yes, sir.
you advise or you advocate that it should be
After the
excised
pterygium excision. Yes.
and then wait for few months, then do the surgery.
Yes.
And if it is less than 2 millimeter, then
Sir, the significant myopic shift is not more than 0.5 diopters. While going through multiple studies as well as our own conclusion, we found out that if the pterygium size is more than 2 mm,
less than 2.
pterygium size is less than 2 mm, then the overall myopic shift is almost equal to 0.5, not more than 0.5. But if it is more than 2, then according to the size, it varies up to 1.5 diopters as well, sir.
So let me ask you again, please. If the pterygium size is more than 2, you advocate that it should be ideally excised first before the cataract surgery.
Yes.
Okay. If it is less than 2, then what you advocate? Change in the IOL powers,
Sir,
or same IOL power?
Sir, we would advise to go for the same IOL power because
And pterygium being a progressive condition,
yes, sir.
what will happen if you...
Sir, if we
Okay, so this is a critical thing I'm just asking.
yes,
Thank you.
yes, sir. Sir, cataract surgery would be advisable because the refractive correction would be less. But after the cataract surgery, we would advise it to go for a pterygium excision. We can go for in pterygium less than 2 mm, we can go for a combined surgery as well. Combined surgery.
That is what
Yes.
that is what
Combined
I'm
surgery
asking.
would have been a better option.
It's a simple answer that if it is more than 2, you do it sequentially.
Yes.
First the pterygium, then the cataract.
Combined
If it is
surgery.
less than 2, then you can do simultaneously.
Yes,
Where is the
combined surgery? Yes.
That's all right. Thank you. ये नहीं आया ना, ये लास्ट के पहले वाले पेज के दोनों लास्ट 2 और अगले वाले पेज के 2 बस ना.
Thank you very much, all the presenters, and all the very best for your future work. Please come forward for a group photograph.
इसके लिए पापा नहीं दिया.
please come. Come for a photograph then.